Professor Stephen Atkin here, and I'm going to talk to you about the RCSI research response to COVID-19. As this audience knows, the coronavirus disease 2019 is caused by the severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, that has resulted in a global pandemic. And as of December the 11th, 2020, over 69 million cases have been confirmed worldwide, leading to over 1.5 million deaths. There are several current vaccines that are being rushed into approval, and here in Bahrain, we're going to have the Pfizer mRNA virus vaccine, and we're going to have the Sinovac Chinese inactivated virus vaccine. On the surface of the coronavirus, there's a spike protein, and this spike protein interacts with the angiotensin-converting enzyme 2, transmembrane metalloprotein. It binds and it allows the virus access to the inside of the cell, where it then replicates. Common symptoms of COVID-19 include fever, cough, breathing difficulties, and loss of taste. And the loss of taste can actually take a long time to actually recover. In more severe cases, it can lead to pneumonia, severe acute respiratory syndrome, the development of a coagulopathy, multi-organ failure, and death. It's shown here, if you've got certain comorbidities, then it increases the risk that you're going to get severe disease. So on the top, one can see 3 particular studies, 2 from China and 1 from Italy. And down on the left-hand side, you can see the comorbidities. And what this shows is that those patients with hypertension have a marked increased risk of severe COVID-19 disease, as do those with diabetes, followed by cardiovascular disease and cancer, where patients obviously are immunocompromised. And surprisingly, chronic obstructive pulmonary disease, while still a risk factor, isn't as significant as those who have hypertension and diabetes. So to combat the SARS infection, there have been a number of drugs have been suggested that might be of benefit in these people. So for example, there's hydroxychloroquine, which I'm sure you've heard of, chloroquine, and baricitinib, and they directly affect the virus and prevent protein synthesis, such as lopinavir and ritonavir, whereas remdesivir, favipiravir, and ribavirin all affect the RNA-dependent RNA polymerase and prevents viral replication. Other drugs, such as tocilizumab, affect the IL-6 receptor, damping down the immune and cytokine response. However, so far, only remdesivir has really been found to have some effectiveness in COVID-19 disease, reducing hospital stay by a few days and being of some value in severe COVID-19 disease, but everything else has not been very successful. So turning now to the detection of the SARS-CoV infection, what we know is that there are patients who are initially asymptomatic, and the gold standard for the detection of the virus is reverse transcriptase polymerase chain reaction, which is incredibly sensitive. But in those patients who are asymptomatic, RT-PCR can still be negative. Then in the symptomatic phase, these patients then become positive. And whilst the RT-PCR has got a false negative rate, it is very low. Patients then, as I say, develop symptoms, and when the viral RNA becomes evident, Following that is the convalescent phase, and when the RT-PCR again becomes negative as the virus is cleared from the body, and then the full recovery phase, where again RT-PCR is negative. However, in the convalescent phase, there's the detection of IgM antibodies, and in the full recovery phase, one can see that there is increase in the IgG antibodies. But what we don't actually know is the length of time you are protected by a COVID-19 infection. What we do know is that there are people who had the infection twice. Normally, if you get a second infection from a viral illness, then it tends to be much less severe than the first. However, there's been a number of cases documented where, in fact, the severity of the infection has been far greater the second time round. So this leads us to the question, how often is COVID-19 asymptomatic? and to answer that question, together led by Professor Manaf Al-Qutani of the COVID task force, we then looked at this specifically. And this was based on the individuals that were coming in to Bahrain International Airport. Well, those that came in from high-risk countries all underwent mandatory quarantines. 2,714 individuals underwent mandatory quarantine. And of those, 136 individuals were viral positive on arrival. And of interest, the majority, 92, were asymptomatic. These individuals who were found to be positive but asymptomatic went off to the hospitals. Those individuals who were negative were still put into mandatory quarantine in a government facility. If they had symptoms, they then were immediately tested. But at the end of 14 days, all patients were tested irrespectively. And what was found is that a further 52 individuals became viral positive over that 14-day period. And of the 24 subjects found to be viral positive at day 14, they remained asymptomatic until viral clearance. And that is shown here. So with 2,714 subjects, 2,526 tested negative. 188 tested positive, either on arrival or in the subsequent follow-up period, 90 male and 98 female. Of those 188, 136 tested positive on arrival, only 44 were symptomatic. Their viral clearance was between 6 and 13 days. 92 were asymptomatic, non-developed symptoms, and they had the same viral clearance as those who were symptomatic. So of the 52 who tested negative on arrival, 27 developed symptoms and were confirmed positive on days 2 to 13. And again, they showed viral clearance of between 6 and 13 days. But 25 became asymptomatic, tested positive on routine testing on day 14 of quarantine. One became symptomatic 5 days later, on day 19, but 24 remained asymptomatic, viral clearance between 6 and 14 days. So the time to viral clearance for those who detected as positive on arrival was around about 13 days. Those asymptomatic was around about 12 days. Those who tested positive at day 14 had a shorter time to viral clearance at around about 9.4 days compared to those who were asymptomatic on arrival. So in conclusion, and that we published in the International Journal of Infectious Disease, asymptomatic patients with the SARS-CoV-2 infection were found to be positive 14 days after initial testing and remained symptomatic until viral clearance. Asymptomatic patients with COVID-19 were more prevalent than those exhibiting symptoms, and they are an infection risk and requiring multiple testing for detection. So one of the other things that we wanted to know is that there's a high prevalence of sickle cell disease here in Bahrain, and as I showed you previously, if you have a comorbidity, that increases the risk of more severe COVID infection. Therefore, what we wanted to do is look at see whether or not those patients with sickle cell disease were more prone to severe COVID-19 infection, and therefore need to take specific precautions for this population. Now, sickle cell disease results from mutation in the hemoglobin beta chain, and 1% of the Bahraini population are affected. It results in what we call sickle crises, which can be very painful and life-threatening. What we do know is that the SARS-CoV-2 may decrease the oxygen carrying capacity of the hemoglobin molecule, and therefore the potential that this could be compounded if you had sickle cell disease. And therefore, if the two together, SARS-CoV-2 plus the sickle cell disease, may lead to the sickle crisis, which may even make the severity of the COVID-19 far worse. So mass screening of the Bahraini population was undertaken between February and April 2020. In that period, over 38,000 Bahraini people were tested for COVID-19, of whom 378, 1%, had sickle cell disease. 6 patients with sickle cell disease had COVID-19, that's 1.6%. 3 remained completely asymptomatic. 2 had mild symptoms, and only 1 had moderate COVID-19 disease that required oxygen therapy. So the sickle cell patients had the same similar average length of stay when compared to non-sickle cell disease COVID-19 patients. So therefore, what we can conclude is that there's no increased disease severity in those patients with COVID-19 and sickle cell disease, and no patient with sickle cell disease underwent a sickle cell crisis who were infected with the SARS-CoV-2 infection. And that SARS-2 occurrence rate didn't really differ between those with and without sickle cell disease. So no specific precautions need to be undertaken in those patients. And indeed, this is another paper that was published in the International Journal of Infectious Disease. So changing gears now, what I want to talk about are the clinical trials that RCSI has sponsored and supported the COVID-19 task force and undertaken. And I have to pay a great deal of gratitude and respect to our alumni who actually took on those trials and were in the COVID-19 centres to make the trials a success. So turning first to the convalescent plasma therapy trial. In March 2020, the FDA of the United States authorized the use of convalescent plasma as an emergency treatment for severely ill COVID-19 patients, based on some anecdotal reports of major improvement that came out of China. So it wasn't for prevention, it was for treatment. So convalescent plasma therapy is the transfusion of the fluid component of blood, plasma, from those individuals who have already been previously infected with the SARS-2 virus and who have got antibodies against the virus. And these antibodies are neutralizing and therefore will hopefully, would reduce the severity and length of the disease. So in China, in a non-controlled case series, 5 critically ill patients with COVID-19 disease made a full recovery following such treatment. In an independent feasibility study, 10 patients demonstrated significant improvement in clinical outcomes with minimal adverse effects after a few days after receiving a single transfusion of convalescent plasma. And basically, as I say, the way that it works, you have your neutralizing antibodies in the blood, and these bind to the actual circulating virus in the plasma and prevent it from interacting with the ACE2 protein, and therefore it does not enter the cell. So we here in Bahrain did a randomized controlled trial of plasma therapy. And we didn't know the number of patients necessary for a definitive trial, and therefore a pilot trial was undertaken. And the objective of the pilot trial was to compare plasma therapy using convalescent plasma with antibodies against the SARS-CoV-2 and compare to usual supportive therapy in COVID-19 patients with pneumonia and hypoxia, and to determine if the clinical course is improved. And then the difference between the groups would allow an effect size to be determined, and that effect size would guide us on the number that we needed for a definitive clinical trial. So the research question was, could using convalescent plasma transfusion from recovered COVID-19 patients with antibodies against COVID-19 be beneficial in the treatment of these patients with hypoxia and pneumonia in order to avoid or delay the need for nasal ventilation? So these were patients who had moderate or severe COVID-19 disease. It was a prospective, interventional, randomized, open-label trial with 40 patients with COVID-19 who were all in respiratory distress that required oxygen therapy, and they had to have radiologic evidence of pneumonia. They were randomized into either one receiving transfusion of the convalescent plasma plus routine care, or into routine care alone without the convalescent plasma. So it was designed, as I said, to guide a definitive phase 3 clinical trial. What we found is that there was no differences in the primary outcome measures between convalescent plasma and standard therapy, although fewer patients required ventilation for a shorter period of time. And there was no difference in the secondary outcome measures, that was the ferritin, procalcitonin, CRP, white cell count, between convalescent plasma and standard therapy. We determined that convalescent plasma therapy appeared safe and was feasible to perform a definitive phase 3 clinical trial using the study protocol, and from the effect size that was calculated, it would take around about 800 patients to be treated and randomized for a definitive outcome to be determined using convalescent plasma. Now, as mentioned before, that a number of drugs have been used to see if we can either prevent infection or to reduce the severity of infection, to treat the infection. And one of those drugs is Fibropyramia, which affects the RNA-dependent RNA polymerase. So Fibropyramia is an antiviral drug that was developed in Japan. It's a pyrazine carboxamide derivative with activity against influenza, with which it was designed, and was then subsequently shown to have effects against West Nile virus, yellow fever virus, foot and mouth virus, as well as the flaviviruses. And therefore, because of that profile, it was thought that it may have activity against the SARS-CoV-2 virus. Its mode of action is through the inhibition of the viral RNA-dependent RNA polymerase. And there's a report published in the press comparing Fibropyramia with lopinavir and ritonavir, suggesting that Fibropyramia was superior for the prevention of disease progression and viral clearance. So the primary objective was to compare, and again this was a pilot study because we've got no other studies on which to actually do a proper power analysis. The objective of the pilot was to compare the three arms of hydroxychloroquine, Fibropyramia, standard care with no specific SARS-CoV-2 treatment in symptomatic patients who were infected by SARS-CoV-2 in an open-label randomized clinical trial. And the difference between the groups would then allow a proper effect size in order to power a definitive trial. Now, I've mentioned that this trial was and is ongoing at this precise moment. We've recruited 50% of the patients to date and been supremely supported by the alumni who are working in the COVID centres, not only to help recruit the patients, but also to gather all the data that's necessary for the clinical trial. 50 patients have been standardized as standard therapy, 50 patients have been randomized to hydroxychloroquine therapy, and 50 patients are going to be randomized to the Fibropyramia. So as I say, this trial is ongoing at the moment, and therefore there's no further results to actually report to you at this precise moment. So in summary, RCSI is supporting the COVID-19 task force through, firstly, sponsoring the clinical trials, allowing them to happen. Secondly, providing clinical trial staff to undertake the clinical trials actually on the ground in the COVID centres. Thirdly, collaborating on the data analysis from the data that's been generated in this pandemic. And there are currently 19 other additional projects which are ongoing that are requiring further input from RCSI to actually make them happen, which includes also collaborating on the data interpretation and the statistical analysis. And we're also collaborating on the dissemination and publication of the research results. And so far, several publications have resulted from this work in peer-reviewed international journals. Thank you for your attention.